Good morning, everybody, and welcome to our presentation. We're really sorry about the technical glitches and the delay. This morning's presenter is Dr. Nadia Swart. She graduated from the University of Pretoria in 2014, after which she did her internship at one military hospital and community service at Brits District Hospital. Nadia developed a passion for emergency medicine after she started working in private emergency clinics in Gauteng in 2018. She became a flight doctor in September 2018 and had completed more than 150 fixed-wing flight missions. She also obtained some ICU experience working as a medical officer in ICU at Mediclinc Midstream and later the Unitas Hospital. Swart is a mother of one and a cancer survivor after completing chemotherapy for Hodgkins Lymphoma in March of 2024. Thank you so much for preparing this presentation for us.
Thank you, everyone, and good morning. I'm sorry about the technical issues. I'm definitely not an expert in the subject, but over the past year, I've seen an increase in patient presentations that are related to cannabis, and this inspired the topic. So cannabis or marijuana is the fourth most commonly used psychoactive substance in the world after alcohol, caffeine, and tobacco. It can be used by smoking, vaping, dabbing, ingesting it, or applying it as a topical cream. 4.4% of the global population aged between 15 and 64 used cannabis in 2022, and about 3.5 million people initiated cannabis use in 2023, of which 33.8% were aged 12 to 17 years. Cannabis has unique sedative and anesthetic properties, and these psychoactive properties are primarily due to the cannabinoid THC. THC concentration is commonly used to measure the potency of cannabis, and this has increased significantly over the past 20 years. The potency and legalization of cannabis may have contributed to the increased rates of cannabis-related adverse events. Okay. Types of cannabinoids discuss endocannabinoids, which are produced in the brain and peripheral tissue, naturally occurring cannabinoids, which are plant-derived. The cannabis plant is a mixture of more than 100 identified phytocannabinoids, terpenoids, and flavonoids, of which are psychoactive. And then synthetic cannabinoids, which are chemically engineered synthetic compounds with cannabinoid-like action, but it does not necessarily have a phytocannabinoid chemical structure. There are two known cannabinoid receptors in the human brain. Cannabinoid 1 receptor, which occurs in the central nervous system, acts presynaptically and inhibits the release of neurotransmitters such as acetylcholine, albuterol, epinephrine, dopamine. And the cannabinoid 2 receptor, which is found in the immune system, peripheral nerve terminals, and vas deferens, and it plays a role in the regulation of the immune response and inflammatory reactions. The most important cannabinoid to this THC, which binds to this cannabinoid 1 receptor. Its absorption depends on the route of administration. When inhaled, it generally has a fast action, an increased bioavailability, and a shorter duration of action as compared to oral ingestion. It's metabolized in the liver. It's distributed to fatty and highly perfused organs, fatty tissue and highly perfused organs such as the brain, lungs, and liver. It is 95% protein bound. Kidneys, and
If everyone can just ensure their mics are turned off, please.
CBD has a much more complex mechanism of action. The absorption also depends on the route of administration. It's also metabolized by the liver and distributed to fatty tissue and highly perfused organs, and is eliminated through feces and urine dependent on the route of administration. Currently, no cannabinoid medication is approved by SAHPRA and can only be obtained through Section 21 application. Previously, Marinol or Dronabinol was approved and was used to treat anorexia and weight loss in adults with AIDS and chemo-associated nausea and vomiting in adults who failed conventional therapy. This drug is similar chemically similar to THC and binds to the cannabinoid 1 receptor. Synthetic cannabinoids are chemically engineered synthetic compounds. They have chemical structures. The chemical structures of these compounds determine its nomenclature, and it's consistently being changed to avoid regulation. Such changes may introduce additional and unpredicted toxic and clinical effects. It's a partial or full agonist at the cannabinoid receptor, and it generally has a potency of 200 to 800 times greater than THC, metabolized in the liver and eliminated by the kidneys. Some of the adverse effects of cannabis use include acute cognitive impairment, and this is generally dose dependent. It can cause neuroimaging changes, which may show a decreased hippocampal volume and gray matter density. It can lead to psychiatric effects, such as increased risk of psychosis, mood disorders, anxiety disorders, and substance use disorders. It has effects on the eye, which decreased intraocular pressure, increased photosensitivity, decreased tear production, conjunctival injection, eyelid tremors, and horizontal nystagmus. It also has oral effects. It causes xerostomia, leukoplakia, periodontitis, and bruxism, and it can increase the risk of oral cavity, pharynx, and esophageal cancers. It can cause asthma and lead to asthma exacerbations. It can increase the risk of swelling, self-carcinoma of the lung. It can cause bronchospasms, and breath holding when smoking can cause pneumothorax or pneumomediastinum. In prolonged use, it can increase the risk of cardiovascular disease, including angina, MI, and stroke. Gastrointestinal, it can lead to cannabinoid hyperemesis syndrome, decreased gastrointestinal motility, and delayed gastric emptying, and it can increase the appetite. It increases the risk of non-seminoma testicular cancer. It possibly reduces spermatogenesis and impairs sperm function. And then it's excreted in breast milk at rates of 2 to 6 times higher than the plasma concentration of the mother. It crosses the placenta with fetal plasma concentrations of 10 to 30% of the maternal concentration. And this causes an increased risk of low birth weight, small for gestational age, and NICU admissions in neonates. And it also increases the risk of emergency department visits and hospitalizations. Some of the possible benefits of cannabinoids includes that it can be used for pain management, to decrease neuropathic pain, decrease fibromyalgia pain, and may provide analgesia in some cancer patients. It can increase the appetite and cause weight gain in cachexic patients. It can have an anti-emetic effect. It can reduce chemo-induced nausea and vomiting. It can be used to decrease spasticity in multiple sclerosis patients. It can be used in specific epilepsy syndromes such as Dravet syndrome and Lennox-Gastaut syndrome to decrease the frequency of seizures, and it may also improve sleep in patients with sleep disturbances due to certain chronic disease states. One of the very common cannabis-related emergency unit presentations is due to acute cannabis intoxication. Cannabis is the most cultivated, trafficked, and abused illicit substance in the world. In adults, inhaled doses of 2 to 3 milligrams THC and ingested doses of 5 to 20 milligrams THC may impair attention, concentration, short-term memory, and executive functioning. Doses of more than 7.5 milligrams per meter squared total body surface area THC may cause nausea, postural hypertension, delirium, panic attacks, anxiety, myoclonic jerking, and acute psychosis. Children generally tend to ingest cannabis accidentally or intentionally, and ingested doses of 5 to 300 milligrams can lead to lethargy, ataxia, behavioral changes, hyperkinesia, seizures, coma, and even respiratory depression. A dose of 0.15 to 0.3 milligrams per kilogram THC is required to achieve a psychotropic effect. 0.45 to 0.6 milligrams per kilogram can cause mild intoxication. With doses of more than 1.7 milligrams per kilogram, you will generally have significant symptoms that last more than 6 hours. And with doses of more than 2.3 milligrams per kilogram, you can have severe intoxication with cardiovascular effects, respiratory depression, and neurological effects that require intervention. Some of the cannabis may have many neuropsychiatric effects, which can cause changes in mood, perception, and thought content. It can cause euphoria, decreasing anxiety, and decreasing depression, but it can also lead to negative symptoms that include anxiety, dysphoria, panic dysphoric reaction, and social withdrawal. It also causes impaired cognition and psychomotor performance, perceptual changes, distorted time and space perception, hallucinations, paranoia, and psychosis, and it can slow reaction time, impair cognition and motor coordination, and decrease the ability to perform complex tasks. And the psychomotor impairment can last 12 to 24 hours. Some of the signs of acute intoxication in adults and adolescents include tachycardia, tachypnea, hypertension, orthostatic hypertension, conjunctival ejection, nystagmus, dry mouth, increased appetite, ataxia, slurred speech, hyperemesis, behavioral problems, dysphoria and agitation, and anxiety. Children generally have the same symptoms, but they may also have euphoria, lethargy, irritability, behavioral changes, depressed mental status, bradycardia, and dilated or constricted pupils. The diagnosis is made through history and clinical examination and a positive urine drug screen test for THC. We need to consider additional investigations if complications are present and other causes are suspected. This includes ECG, cardiac biomarkers, chest X-ray, and other bloods. And in children, a possible LP and neuroimaging should be done to exclude other causes of central nervous system depression if no known cannabis exposure. The treatment of acute intoxication depends on the severity of the symptoms. Mild symptoms are generally treated through reassurance, place patient in a dimly lit room, and to decrease stimulation. With severe intoxication, it's treated as above, but then we add benzodiazepines, and we might need to manage according to the acute agitated or violent patient protocol. With CNS depression, we provide supportive care to the ABCs, and if you also suspect an opioid poisoning, you may give a test dose of naloxone. We need to monitor the HTT. With seizures, we try and abort them with benzodiazepines, and then you treat it according to the status epilepticus protocol. And agitation and anxiety you can be treated with benzos. Any other complications should be managed according to the etiology. Patients should be admitted if there is prolonged CNS depression, persistent agitation, and delirium, persistent vomiting, seizures, and hyperkinesia. For any advice, call the Poison Information Center 24-hour helpline. We also need to look at acute intoxication due to synthetic cannabinoids. These are chemically synthesized compounds which are sold as a chemical itself or added to herbs to give it a natural appearance. Names include K2, Spice, Crazy Monkey, Chill Out, Spice Diamond, Spice Gold, Chill X, or by its chemical nomenclature. Clinical effects are similar to cannabis, but they have a greater potential for serious neuropsychiatric toxicity, including hallucinations, delirium, and psychosis. And they can cause life-threatening toxicity with severe agitation and seizures. Symptoms are similar to cannabis intoxication. With mild to moderate symptoms, you generally get a tachycardia, agitation, vomiting, and the duration of these symptoms generally lasts less than 8 hours. You also get severe symptoms with psychomotor agitation, toxic psychosis, hallucinations, delirium, dystonia, paranoia, seizure, and coma. You may develop a brady or a tachycardia, can develop hyperthermia or respiratory depression. And some of the complications include acute kidney injury, rhabdomyolysis, asthma or asthma exacerbations, ischemic stroke and subarachnoid hemorrhage, angina, myocardial ischemia, coagulopathy, and even death. The diagnosis is made by history and clinical examination alone. A rapid urine drug screen will not detect a synthetic cannabinoid. Additional investigations should be done for complications or other suspected causes. If the patient has severe agitation or seizures, you need to check for rhabdomyolysis, stroke, intracranial hemorrhage, and acute kidney injury. This can be done by bloods, including glucose, ABG, FBC, UME, and serum tox screens. You can also do a urine dipstick tox screen, monitor the O2 sats, a 12-lead ECG monitoring, a urine pregnancy test in females, and in patients with seizures, neuroimaging should be done. For chest pain, a 12-lead ECG, chemical biomarkers, and a chest X-ray need to be done. And for clinically significant bleeding, you need to do a clotting profile, FBC, a type and screen, urine dipstick for blood, and a urine stool for cold blood. The treatment of synthetic cannabinoid intoxication is also dependent on the severity. For mild to moderate intoxication, you provide reassurance, don't we let room, decreased stimulation, but we also add a benzodiazepine. And then for severe intoxication, you treat it according to the significant findings. For agitation, you generally give benzodiazepines, but they may not respond, and then you need to treat the patient according to the management of aggression patient protocol by administering a rapid-acting first-generation antipsychotic such as haloperidol. You may need to consider manual restraints, and you may even need to give a ketamine, Persidex, or propofol infusion. For hypothermia, you need to do augmentation of evaporative cooling and adjuncts to cooling. You give a benzodiazepine, and if there's marked hypothermia, responding to the above measures, then you need to consider intubation and paralysis to stop regeneration by muscle activity. In this case, you'll use rocuronium and not succinylphonium, as sux may worsen the hypothermia and lead to malignant hypothermia. There's no role for antibiotic agents. Rhabdomyolysis should be treated by high-dose fluid administration, usually 20 to 40 milliliters per kilogram per hour, with a goal of a urine output of 4 ml per kg in children and up to 200 ml per hour in adults. And then you also need to treat the associated electrolyte abnormalities and hypoglycemia. Seizures in these patients need to be aborted by benzodiazepines, and then you need to treat to load the patient with anticonvulsant, generally phenobarb, as phenytoin are not ineffective in these patients. And then you need to manage it further according to the status epilepticus protocol. Dystonia can be treated by short-acting benzos, and then you manage the other complications according to the etiology. Cannabinoid hyperemesis syndrome is another possible cause for presentation to the emergency unit. It was first described in 2004. It's a functional gut-brain axis disorder and is a variant of cyclical vomiting syndrome. Its characteristics are episodic nausea and vomiting, abdominal pain. It's associated with prolonged high-dose cannabis use. It's worsened with cannabis intake. It resolves with cannabis cessation. And there's compulsive hot showering and bathing to provide temporary symptomatic relief. It's typically more common in male, older adolescents and adults, and early recognition is essential to prevent complications related to severe volume depletion. Cannabinoid hyperemesis syndrome case study, looking at a patient, a 24-year-old male. He first presented to our unit in May 2021 with a history of vomiting, abdominal pain. He reported binge drinking and smoking marijuana. In clinical examination, he had epigastric tenderness. He had insignificant basic bloods, and he felt better after IV tramadol, Pantocid, and Zofran, and was discharged as an alcoholic gastritis. A month later, with the same symptoms, but this time reported decreased alcohol intake. He had a normal abdominal ultrasound. He was referred for a gastroscopy the next day and discharged from the emergency unit as a peptic ulcer disease. He presented again in 2021 twice, first with treated as an acute gastroenteritis, and in November 21 treated as a gastritis. In January 2022, he was again treated as a gastritis, and on his second presentation, for the first time, a cannabis-induced hyperemesis was suggested and discussed with the patient. He had a positive urine tox screen, otherwise normal bloods, but he was admitted for the surgeon as an acute pancreatitis as suggested on CT abdomen. And he had another 3 presentations to our emergency unit in 2022, generally treated as a gastritis or an acute gastroenteritis. In 2023, end of 2023, we saw him again, and he was admitted as a gastritis in September, and then again twice in October as an acute gastritis, and referred to surgeon as an outpatient. Patient then presented again with the alcoholic gastritis in 2024, and twice treated in June as an alcoholic gastritis. In November 2024, the patient was presented again, but he was a very poor historian and didn't want to volunteer any information. He reported abdominal pain and vomiting for 1 week despite antiemetics. The patient denied drinking alcohol since his last emergency unit visit. On arrival in the EC, the patient asked to go shower. After 30 minutes in the unit, the patient again requested to go shower. Bloods, abdominal X-ray, and abdominal ultrasound was normal, and the patient was admitted for the surgeon as a gastritis for a gastroscopy. After the patient was discharged from the unit, I realized that the compulsive showering in EC was probably due to cannabinoid hyperemesis syndrome, and the diagnosis was made. I contacted the patient and did extensive counseling on cannabinoid hyperemesis syndrome and gave the patient without a drug abuse program, as the patient probably has more than one substance use disorder, including alcohol and cannabis. The patient had a total of 15 emergency unit visits to our unit alone over 4 years. He had a total of 5 admissions with 5 gastroscopies. And after November 2024, we had no subsequent visits. The pathophysiology is not well understood in cannabinoid hyperemesis syndrome. Normally, THC stimulates the cannabinoid receptors, which regulates the emetic centers of the brain. It decreases gastric secretion and motility and decreases the perception of pain. In CHS, however, overstimulation of these receptors lead to loss of regulation of these processes. Intoxication of the endocannabinoid system results in paradoxical response to THC, causing intractable releases, visceral pain, and anxiety. Repeated cannabinoid use also leads to loss of endogenous thermoregulation, causing hypothermia, which further triggers nausea and vomiting, and it may explain the behavioral component of seeking hydrotherapy. Hot showers or baths stabilizes the hypothalamic thermostat, which is altered by the chronic cannabis use. It is also seen in other functional nausea and vomiting disorders, but probably aggravated by cannabis, thus more closely related to cannabinoid hyperemesis syndrome. Cannabinoid is also lipophilic and accumulates in the adipose tissue. During fasting, the stored cannabinoids are released by lipolysis and degrades into proemetic agents, which precipitates hyperemesis. THC is also an agonist for the TRPV1 capsaicin receptor, which plays a role in nociception and has a potent antiemetic effect. Overstimulation of this receptor from cannabis use can cause downregulation and can lead to abdominal pain, nausea, and emesis. THC induces splanchnic vasodilation and cutaneous vasoconstriction, called cutaneous stealing syndrome, and leads to abdominal discomfort. Applying heat to the skin through hot showers may reverse the syndrome and mediate the antiemetic effect by activating the peripheral TRPV1, including inducing peripheral vasodilation, redistributing blood flow from the gastrointestinal tract, and mediating the gut-brain signaling responsible for the emetic effect. The cannabinoid hyperemesis syndrome is made by clinical diagnosis. The symptoms generally occur after chronic cannabis use. There's intractable vomiting, retching with no other identifiable causes. There's a fear of vomiting, loss of appetite, intense abdominal pain or discomfort. There's a positive urine THC screen or a history of recent cannabis use. The symptoms generally last 3 to 4 days, and there's a patient in between, period in between when the patient is well and without symptoms. The symptoms do not respond to customary antiemetics and analgesics. And hot showers and bathing may ease the symptoms. There's an absence of symptoms suggesting the need for surgical intervention. The diagnosis of CHS is ultimately a diagnosis of exclusion. The symptoms depend on the phase of the syndrome. There's a prodromal phase of abdominal pain, morning nausea, and fear of throwing up. And there's a hyperemetic phase, which is the characteristic phase of chronic hyperemesis syndrome, and the episodes last 24 to 48 hours. And then a recovery phase where there's cannabis cessation, and the symptoms improve over days to months and then ultimately resolve. The treatment for cannabinoid hyperemesis syndrome is IV fluids, hydrothermotherapy as needed by the patient, which include hot showers or baths. Then you can treat it with a dopamine agonist such as haloperidol. Just make sure that the patient doesn't have a QT prolongation. You can give a antiemetic, such as ondansetron or metoclopramide, but they're typically ineffective. For persistent symptoms, you can apply capsaicin cream over the abdomen, which may relieve the symptoms, and you can try another antiemetic with a different pharmacological property, and you can administer benzodiazepines such as lorazepam 1 milligram IV with caution due to the dependence risk. You generally need to avoid opioids, especially in patients with recurrent presentations for pain. In long term, the treatment is abstinence or a referral to a substance abuse program. And if the patient is unable to abstain, you immediately advise the patient to use products with lower THC concentrations or reduce the frequency of use until abstinence is possible. A more chronic course of presentation to the EC includes cannabis use disorder. It's a problematic pattern of cannabis use that results in clinically significant functional impairment or distress, with at least 2 manifestations occurring within a 12-month period. Its defining feature is the loss of control over cannabis use and persistent use despite recognizing adverse consequences. It's classified as mild, moderate, or severe depending on the number of symptoms present. It develops in approximately 10% of regular cannabis users and develops in up to 50% of chronic daily users. It usually develops after several years of at least weekly use. If there's an increased frequency, longer duration, and more potent products, increases the risk of developing cannabis use disorder, and it may be associated with cognitive impairment, poor school work performance, and psychiatric comorbidities such as mood disorders and psychosis. The symptoms are clinical presentation may prompt screening, such as a history of impaired social, academic, or vocational functioning not otherwise explained, exacerbation of conditions known to worsen with cannabis, such as mood disorders and anxiety, and then chronic conjunctional injection, cannabis odor, increased appetite, and yellowing fingertips. You can screen the patient by asking questions such as how many times in the past 12 months have you used cannabis, or how many days in the past 12 months have you had a strong desire or urge to use cannabis. And you can use drug screening questionnaires. You can do a urine drug testing, and it may test positive for up to several weeks in chronic users. And you need to assess the risk and severity according to the DSM-5 criteria. I'm not going to go into the details of the DSM-5 diagnosis, but you can just read through that. And the patient must have these symptoms to be diagnosed. You specify the severity according to the number of symptoms. 2 to 3 symptoms is a mild disease. With moderate, you have 4 to 5 symptoms, and with severe, you have 6 or more symptoms. The approach in the emergency unit to treatment of these patients is generally screening, brief intervention, and then referral to treatment. You can treat the acute intoxication, withdrawal, and complications, and then do brief intervention with one to two short counseling sessions, preferably via registered counsellor or counseling psychologist, and then refer for definitive management by psychosocial intervention, substance abuse program, counseling for substance use disorders or mutual help groups. And then for more information, you can call the substance abuse helpline 0800 121314. Patients also present to the unit in cannabis withdrawal. Phytocannabinoids are a partial agonist of the cannabinoid receptor 1 and 2. The downregulation of the cannabinoid 1 receptor occurs due to increased endogenous and exogenous exposure to cannabinoids, and the cessation of exogenous cannabinoids with decreased agonist activation leads to cannabinoid 1 receptor hyperactive state, leading to withdrawal symptoms. Upregulation takes place over time to normal pre-cannabis levels, and symptoms are non-specific. They can be disabling and inhibit attempts to decrease or abstain from cannabis use. The primary risk factors include the frequency and the recency of cannabis use. It occurs in plus minus 30% of individuals with cannabis use, irregular cannabis use or cannabis use disorder.
Oh, yeah. No.
THC is strongly associated with cannabis withdrawal, whereas CBD is not generally associated with cannabis withdrawal symptoms. The symptoms may be mild to severe. They generally appear in 24 to 72 hours after cessation. The peak intensity is within the first week, and it generally resolves within 1 to 2 weeks, but may be longer with synthetic cannabinoids. The symptoms include sleep disturbance, irritability, anger, anxiety, headache, depressed mood, restlessness, decreased appetite, abdominal pain, weight loss, tremors, sweating, fever, rigors, and psychosis. Patients can also develop sympathetic autonomic hyperactivity, more commonly in synthetic cannabinoid withdrawal, with tachycardia, hypertension, diaphoresis, seizures, and altered mental status. The diagnosis is also made by DSM-5 criteria, which you can go through. Most of these resolve without any formal treatment. The patients generally self-treat through exercise, relaxation techniques, over-the-counter analgesics, sedatives, or hypnotics, or alcohol use. The sleep disturbances can be treated with zolpidem or metrazepam. And then other severe symptoms may be treated with synthetic cannabinoid medications, of which none are currently approved by SAHPRA in South Africa. You can try gabapentin and also send the patient for cognitive behavioral therapy. And then synthetic cannabinoid withdrawal, you need to treat the symptoms, agitation generally through benzos, psychosis by second-generation antipsychotics, seizures by anticonvulsants, and then kidney failure, you may need to give dialysis. Thank you. I hope this helps as a guide to managing patients presenting to the emergency unit with cannabis-related disorders.
Thank you so much. That was really an amazing presentation with lots of detail and something that we see very, very often actually. And I think what's always odd to me is people's skewed perception of the effects of cannabis and how there sometimes is complete denial of any negative effects that can present with the drug. And there's a lot of people out there using it on a regular basis, and they don't always volunteer, and it's sometimes we just find it on the talk screen. Can I ask you how long does the urine tox screen remain positive after the use?
If it's a patient with acute use, it can be a couple of days, but in chronic users, it can be several weeks.
Yeah.
After single use. Yeah.
Okay. There's a lot of people online, so I think we probably need to give them an opportunity to ask you something. I mean, this is an expert presentation, so I'm sure you'll be able to answer. If there's anyone that would like to ask anything or make any comments. Any comments? Okay. Thanks. Okay, it means you've answered all the questions. Okay. Thank you so much for for everybody joining. We really had a great turnout today. And thank you for your patience in our technical glitches this morning. I wish you all a good week. Somebody's hands up.
Hi, I thought I'd ask a question. Maybe I missed it, but I just wanted to find out what the incidence and is it getting